Hello, everybody. Welcome back to the afternoon session. I have great pleasure in introducing our next speaker, who is Dr. Paul Nathan, who's a consultant oncologist at both Mount Vernon Hospital and UCLH in London. He's one of the UK and indeed Europe's leading medical oncologists, with a specialist interest in both cutaneous melanoma and, most pertinently to us, uveal melanoma. As before, if you've got any questions, then please save them for later, but you can post them in the chat and we'll have a Q&A after our first two speakers of the afternoon session. For those of you who don't know me, I'm Neil Pierce. If you think, what's that dot on his forehead? Don't adjust your screens. That is what I use to control the cursor, as these days, due to my own little medical problems, I'm pretty much tetraplegic. Anyway, it's fantastic to be with you all. And now I shall hand you over to Paul. Thank you.
Thanks, Neil. And thanks, Joe, for the invitation. And I'm delighted to join everyone today. I'm just going to move to my slides. I've been asked to talk about the guidelines and systemic treatment options. These are my conflict of interests. So we've updated the Melanoma Focus guidelines. And for those of you who aren't familiar with them, we initially published the first set of guidelines around 2015, 2016. In fact, following a discussion at Melanoma Focus, where I was frustrated about the diversity of routes that patients with newly diagnosed primary, newly diagnosed metastatic disease were taking across the country. There seemed to be little coordination, and a number of patients were kind of falling between the cracks in the system. And we really wanted to improve that. And we wanted to do it in a way that was evidence-based, because there's an inverse correlation I've found over the years between the strength of opinion and the lack of evidence. So the less evidence you have, the more opinionated people become about what's the right thing. And so it's really important for the quality of patient care that we try to work in a way that we can justify. And that means using the currently available evidence. So when we did the first iteration of the guidance, it was done in a very high quality way, which allowed NICE to adopt it as recommended guidance, which was a real success actually for the field. And what NICE asked us to do is to update every 5 years the areas in which there had been significant changes. And so that's what we've just done. So the methodology is outlined here. We had open recruitment of guideline development group members. We identified specific clinical questions that were relevant to the change in areas that where there was a change of data over the last 5 or 6 years. We did an appropriate literature search, reviewed the evidence in a robust way. We had discussions and agreements about recommendations. We wrote a draft. It was sent out for widespread consultation, not just nationally but internationally, and then the final document was agreed and written up and published. So this is the guideline development group for this iteration. My colleagues are there. They're all very eminent, and many of you will know them. The one thing I'll point out is that there are no ocular surgeons on this group, and that's simply because in the 5 or 6 years between the first iteration of the guidance and this one, there were no advances in the management of the primary tumor that was significant enough to demand a change in guidance. But these are the areas that are new. We revisited the patient information support areas. There's a whole load of new information on genetic and molecular features of the disease. We touched on adjuvant therapy, both in terms of adjuvant therapy after surgery and as adjuvant radiotherapy for locally advanced tumors in the orbit. We spoke about options for local recurrence and options for metastatic disease recurrence. Now, I'm going to run through these slides, and it will be quick, but the point of it is that at the last slide, there are the links for access. And the bottom line is, if you go to the Melanoma Focus website, there's open access to these, and there are a variety of forms. There's a slide set, there's patient summaries, there's the full guidance. And so please don't feel too shortchanged by the run through today. It's all there for you to have a close look at. So with regard to patient information and support, what we've said is that information should be offered through the pathway in a way that's focused for the patient, and it needs to be information that reaches an appropriate quality standard. We're keen for patients to record their consultations, and please do that in the knowledge of clinicians and staff. I'm very happy if patients ask me to, if it's okay to record their consultations with me, but it's just polite if you say that at the beginning. Patients should be given the time and the opportunity to discuss their condition and treatment on each visit, and that includes risks and benefits of everything that's being suggested, the treatment options, not just locally and at other centres. We do go into the role of tumour biopsy because there are pros and cons with tumour biopsy, and those need to be discussed. And also signposting to other high quality resources like Ocular and Melanoma Focus. Each patient should have a named key worker, and a CNS is often the most accessible person within the team that patients can easily get to. Patients should be given scan results as early as possible to mitigate anxiety. This is an issue across all cancers, as you'd expect, and obviously there are limitations about how quickly you can get a scan result because it's dependent upon how quickly it's reported, and that's a reflection of radiological services. But we just wanted to make the statement that we wanted to make it as a stressful situation as least stressful as possible when we can with patients. We want to make sure that there's information accessed for patients wherever they are in the country on side effects of treatment, whether it's local or systemic, advice for patients and families, offers of psychological support, access to outpatient review or remote consultations, having support family members or friends with them, and early referral to services. And I think, again, these things, most of these things apply to all cancers, and it's just a statement about quality of cancer care and experience going through the cancer system. Now, in terms of prognostic factors, this is a list of things that we want to be recorded about the primary tumour. So we've defined that. If biopsy material is available, again, there are features that we would be keen to record to gain as much information about the tumour as possible. Eye melanoma is a bit curious. It's very different from skin melanoma in many, many ways, to the point where we convinced the European Medicines Agency that it's a distinct disease. One of the great differences is that the genetic landscape in eye melanoma is entirely different, and in fact it's better understood in terms of the relationship with prognosis than with skin melanoma. And so if there is a sample of the primary tumour, we can give more information to the patients about what the risk is to them for the future. Now, that's just information about risk at the moment, but I hope in the relatively near future that will lead on to the possibility of enrolment into adjuvant clinical trials, so trials to reduce the risk of a future recurrence. And we'll only be recruiting patients on adjuvant clinical trials if we know that they have a significantly high risk of recurrence, because you wouldn't want to expose somebody to the potential risk of treatment if they had a low risk of recurrence. And so I think as time goes forward, the arguments in favour of prognostic biopsy will increase, although safety is a major issue, and if the eye surgeons feel that it's unsafe to do, then absolutely it's unsafe to do. So this section pertains to prognostic biopsies and what we wanted to capture from that information. In terms of adjuvant therapy, we don't yet have any proven treatment. So adjuvant therapy means therapy after surgery or radiation treatment to reduce the risk of a future recurrence. There's nothing proven for eye melanoma yet, but this is an area of great clinical need given the proportion of patients who relapse with metastatic disease. And so we're very keen to encourage adjuvant clinical trials, but systemic adjuvant treatment should only be given within the context of a clinical trial because nothing's proven yet. We did talk about radiation therapy after eye surgery. The only tumours that this really pertains to is tumours that have grown outside the sclera, outside the capsule of the eye, because there's a risk of a local recurrence in the orbit. And the evidence for that is pretty thin, but it's an option for high-risk patients. And then for metastatic disease, there's obviously been a great change recently with Tebentafusp, and I'm going to show you some slides on that. And that's why we recommend that HLA-A201 testing is done to know whether or not Tebentafusp is potentially an option for patients with metastatic disease. However, this agent is not yet reimbursed by NICE. For those of you who are aware, the single technology appraisal is still ongoing, and we'll wait and see what happens in the new year. But we're also very keen that patients are referred to clinical trials at other centres. And Tobias Arkenau, who's following me, will be taking you through a number of clinical trials. I'm going to just point you to one area of recent advance. But the message really is to ask your team whether they or you can find out what treatment options are available, what trial options are available. And one of the great things about the Cancer Network in the UK is that we are very functional network, and we refer well to people. When, as many of you may know, we were running the Tebentafusp studies for a long time. We were only one of 2 centres in the UK. For the main study, there were just 3 centres in the UK, including a centre in Scotland. And we had patients coming to us from all over the country. And so those referral pathways do work, but it makes sense that patients ask the question of their teams to understand what's available for them. And in terms of systemic immune checkpoint inhibitors, these are standard treatments for skin melanoma. They are used for eye melanoma. I'm going to show you some data on there. My personal view is that one needs to be careful about who one offers treatment to. Nobody wants to offer treatments that are highly toxic with very low chances of success. And I'll try and take you through pros and cons of those. And then we did make a statement about local regional management of disease that was mainly limited to the liver, because there's increasing data from hepatic artery chemosaturation, and we support that in selected patients. What we didn't address was service configuration, management of the primary tumour, as I mentioned, or indeed surveillance following diagnosis. And the reason surveillance wasn't updated is because, again, in the 6 years since we wrote the original the original guidelines, there was no new data that influenced that. But my colleague Matthew Wheater in Southampton, with the support of Melanoma Focus and Ocular, are getting together what I hope will be a process that results in some updated surveillance guidance. But because of the lack of evidence, this will be more likely a kind of a consensus statement that stakeholders agree with, rather than an evidence-driven statement, although what evidence is available will obviously be fed into it. So I mentioned the Melanoma Focus website, where you can get all of that supporting information from, including patient and carer information. So there's been a lot of work to produce these. I'm thankful to Nancy Turnbull and to Susanna Daniels at Melanoma Focus, and Joe Gums and the team at Ocular. There's a huge amount of work, and hopefully you'll find this helpful. So the other thing that Joe wanted me to talk about was current systemic treatments and its selected emerging things. And so what I'm going to talk about is Tebentafusp briefly, checkpoint inhibitor therapy, particularly combination ipi-nivo, because there's a bit of a groundswell of enthusiasm for ipi-nivo, and I'm a little bit circumspect about it. I'm going to draw your attention to one of a number of investigational agents or combinations of agents in early clinical trial at the moment that are looking interesting, although I'm sure Toby will take on more detail than I'm going to cover. So Tebentafusp is an IMTAC, so it's an immune mobilizing T cell receptor against cancer. Now, my junior medical staff who have done an immunology program at medical school struggle with this. So I think it's quite hard for a non-clinician to get their head around. But what I'd like to point out to you is that antibody-based therapies, whether it's antibodies or other ways of using antibody receptors, just target the inside of the cell. But T cell receptors, and you would have heard of T cells as the lymphocytes that kill COVID-infected cells. T cells are the killing cells within the immune system. They recognize things that originate from within the cell, but are then presented on the outside. So the kind of cell contents are chopped up into short peptides, and these are presented on the surface of the cell, and it's those that the T cell recognizes. But the T cell only recognizes them when they're presented with something called an HLA molecule. And an HLA molecule is the thing that defines histocompatibility. So it's the reasons why if you have a mismatched kidney transplant, the kidney will be rejected because they're not the same immune grouping. So because these T cell receptors only see these intracellular contents when they are expressed by these HLA molecules, it means that the patient has to have the right HLA background, the right immune grouping, to be a candidate for treatment with Tebentafusp. So this is it in more detail. So this is Tebentafusp here. This is the T cell receptor bit. That's the peptide it binds to, which is also stuck to HLA. And as I say, this HLA molecule's got to be the right type. The HLA molecule for Tebentafusp is something called HLA-A2.01, and about 50% of the Caucasian population express or have HLA-A2.01. Then at the other end of Tebentafusp, there's something here that activates T cells that are in the tumor. So I think of Tebentafusp as a molecular bridge. One end sticks to the cancer, the other end sticks to and activates T cells in the tumor nearby, and it introduces the two things together in a way that turns on the T cells and hopefully kills the cancer cells. Now, there was a lot of work that led to this large trial that we published last year in the New England Journal. And so this was the phase 3 study, so the study that led to the approval of the drug. So patients had to have metastatic uveal melanoma, have the right HLA grouping, and they, in this study, didn't have any previous treatment, and they either received Tebentafusp or what was investigators' choice, because before Tebentafusp, there was no standard of care. Patients were offered immunotherapy with ipilimumab or pembrolizumab or dacarbazine. Combination ipi-nivo wasn't an option, but actually outcomes not significantly different, we know now, with combination ipi-nivo than these single agents. Now, the thing about Tebentafusp is it's given weekly by intravenous injection. And the other thing about Tebentafusp is it's pretty toxic, or can be, particularly for the first 3 weeks of treatment. And so patients need to stay overnight in hospital on the day of administration of their treatment for the first 3 or 4 weeks, because it induces something called a cytokine release syndrome, which drops their blood pressure and can cause problems with heart, liver, lungs, and brain. And therefore, patients need to be fit enough to tolerate this. This is the improvement in overall survival in patients who received Tebentafusp compared to those patients who received the other options. In fact, 82% of these patients received pembrolizumab, which is an immune checkpoint inhibitor. And the bottom line is that during the duration of this study, patients who received Tebentafusp had a 50% improvement in the chance of dying during the conduct of the study. This is not a curative treatment; it's a palliative treatment. The median, the average-ish improvement in survival is 6 months. Okay, so the median survival went from 16 months to 21.7 months. So it's a 6-month average benefit in survival. But like all cancer drugs, there are a group of patients who have longer term benefit, but obviously, inevitably, there are a group of patients who have shorter term benefit. I'm just going to show you this. This is just to make one small point. So this is what we call a forest plot. So basically, it looks at subsets of patients on the trial, where they came from, what drugs they received, how old they were, what certain blood tests were, and how much disease they had in their liver. And everything to the left of this dotted line is in favor of Tebentafusp. Everything to the right of the dotted line would be in favor of the standard treatment. And you can see that everything on the left was in favor of Tebentafusp. In other words, all of these groups had more benefit with Tebentafusp than they did with pembrolizumab or the other options they had. However, there are trends here. So patients with smaller volume disease seem to have more benefit than patients with bigger volume disease. And patients with normal blood tests tended to have more benefit than patients with abnormal blood tests. In other words, patients with very advanced disease had less benefit from Tebentafusp than patients with less advanced disease. And when we're thinking about who to offer this treatment to, I think that is something that should influence all of us. The strange thing about Tebentafusp, the interesting thing, is that even in patients whose disease carried on growing, there was still a survival advantage if you received Tebentafusp. So even in patients whose disease was growing, if they received Tebentafusp, on average, they lived for longer than patients who didn't receive Tebentafusp. And that's a very interesting observation, and we're trying to understand that better. We think the drug changes the tumor microenvironment in a way that slows down tumor progression even after the drug's been stopped. So it's an important agent. It's the first drug of this type that increases survival, and it's the first drug we've ever had in metastatic uveal melanoma that's been proved to improve survival. And so that's a huge advance. But I think it's really important to be considered about this. When we've had the first checkpoint inhibitors for cutaneous melanoma, I remember we treated patients who I would never treat now, patients who I know now would not have benefited from treatment because they were too unwell, too poorly, advanced disease was too bulky, or they had comorbidities. We really worry if somebody's got a history of a heart problem, whether they can cope with the cytokine release syndrome that Tebentafusp causes. And so one needs to be able to have conversations with patients in an honest way about the potential benefits and the limits of benefit and the potential risks from this treatment. I'm quickly going to say something about Ipi/Nivo, which many of you will be aware of is used widely for skin melanoma. And there's been a resurgence of use, particularly in the States and a little bit here, with this combination, because there were two small clinical trials. There was this American study from a colleague of mine called Sapna Patel at the MD Anderson, and it's a small number of patients. There's only 30 odd patients, 35 patients, and the 1 year survival was 56%. So 56% of patients were alive at 1 year. Which isn't great. Now, one of the things about this is that they had a lot of patients with extrahepatic disease. So 70% of their patients had extrahepatic disease outside the liver. In fact, 20% of their patients only had disease outside the liver. And many of you will know that that's an unusual subset of eye melanoma patients, because the vast majority of eye melanoma patients who have metastatic disease in the real world have liver disease. And there's a similar study from a colleague of ours in Spain, Josep Pulatz. And again, they showed similar 1 year survival with combination Ipi/Nivo. Now, what Josep did was to look at the outcome of that study and the American study and try and dissect which patients benefit from combination Ipi/Nivo and which patients don't. And it's presented in terms of this hazard ratio, and basically the smaller the number, the greater the benefit from treatment. And what it shows is that if you're one of the rare patients with eye melanoma whose disease isn't in the liver, then this treatment, Ipi/Nivo, confers significant benefit. But if you're one of the majority of eye melanoma patients with disease in the liver or predominantly in the liver, there isn't any evidence that combination Ipi/Nivo confers significant benefit compared to historical patients. So these are the 1-year overall survival figures for Ipi/Nivo. In fact, they're very similar. That's slightly inferior to the 1-year overall survival for the control arm of patients who on the Tebentafusp study, the patients who had single agent pembrolizumab. So the question is, who can you justify Ipi/Nivo to? And it's probably those patients with disease outside their liver. And then finally, I'm just going to show you one new thing that's coming through. One of the exciting things about eye melanoma research is that once you've got, all cancer research, once you've got one breakthrough, it does stimulate activity there. Toby will take you through, I'm sure, a number of different trials that are going on at the moment, but this one is standing out a little bit at the moment. So this is a combination of tablet-based treatments that target certain activating pathways in the cancer cell. One of the drugs is called darovasertib. Darovasertib, I must learn how to say it. And the other one is crizotinib, which is a drug that's used for lung cancer. And this is a group of patients with eye melanoma, and you can see this is a waterfall chart. So each column is the disease burden in an individual patient from baseline. So in other words, 0 is where it started from, and if the cancer got smaller, the bar goes below 0, and if the cancer got bigger, the bar goes above 0. And you can see in this early study, patients with eye melanoma had significant shrinkage of their cancer, and it's not often that we've seen that sort of activity in eye melanoma. So in summary, Tebentafusp is a new standard of care for metastatic eye melanoma. You do need to have the right HLA background. About 50% of the population have that. It's not yet NICE reimbursed. It's a hugely expensive drug in the States, and the issue will be both in terms of confidence about the benefit and an acceptable cost for NICE. And so that's the conversation that's going on at the moment. And remember, it's a palliative treatment. It's not a panacea. It extends average survival by about 6 months, but it is a breakthrough in this area. Ipi/Nivo, it's much less active than in uveal melanoma than in cutaneous melanoma. It's actually only a small minority of patients who have durable benefit, and I think we have to be considered in selecting which patients are offered this because it is so toxic. And with all anti-cancer drugs, you need to make sure that the benefits of treatment outweigh the toxicities from treatment. Otherwise, you end up doing more harm than good. And then finally, there are a number of new agents in early phase clinical trials. There's much greater clinical research activity. I've showed you a tantalizing slide on the darovasertib and the crizotinib combination, but there's many other agents in development that Toby will take you through. But that is exactly why we wrote in the guidelines that patients need to be able to be signposted to centers that are running these studies. Fine, that's my last slide, and I look forward to picking up questions later. Thank you.
Thank you, Paul, for that fantastic overview. I think for me, looking back to where we were when Ocular UK started 11 and a bit years ago, the scene has just changed so much. To be in a position where you can talk about 3 systemic treatments or 3 groups of systemic treatments, where we've actually got trial evidence, we've got increasing ideas of who would benefit, and now we're talking more about funding for something that has got a real possibility of making a difference. Admittedly, Tebentafusp was only for that 50%. If I'm allowed one quick question, when are we going to have a Tebentafusp for the other 50%?
Yeah, it's a really good question. So this technology of using T-cell receptors depends upon having an HLA molecule that the T-cell receptor binds to. Now, I can't speak for Immunocore, who were the company that developed Tebentafusp, but it would be obvious that you can make a panel of agents that hit the less frequent HLA types and cover a greater proportion of the population. There are also other investigational approaches that would be less dependent upon HLA restrictions. So I think, we went through an explosion of progress with cutaneous melanoma starting 10 or 15 years ago, and it's really made a massive difference to outcomes, as you know. And my hope is that we're just on the cusp of that now with eye melanoma. I don't know whether Tebentafusp is going to be the answer for the future, but what it does show is that if you turn on the immune system in the right way, you can have a profound effect on the cancer in this disease and improve outcomes.
Okay. Well, thank you so much again, Paul. So we're going to move on now, but still staying within medical oncology. And this time we have a new guest to us. This is Professor Toby Arkenau, who's a renowned consultant medical oncologist. He qualified in Hanover. He's worked in the UK for most of the last 20 years. And he's currently working as Executive Medical Officer at the Sarah Cannon Research Institute, which is a London-based and world-leading cancer research institute with a particular reputation for the investigation of early phase clinical drug trials. And the professor has got, I believe, over 80 such trials in his portfolio. So I'm particularly looking forward to hearing from him now as he updates us on the role of these early phase drug trials. Over to you. Thank you.
Great. Thank you so much for the introduction. And I hope you can see the slides. There's a bit of a change. I'm not anymore at Sarah Cannon, but I'm still involved in research at UCL and HCA. And I'm actually currently the Chief Medical Officer of a smaller biotech company here in London. So clinical trials in uveal melanoma, Paul has really summarized and given us a very great idea what has happened over the last particularly 2 or 3 years with breakthroughs of immunotherapy. So I will cover some of this, and some of the slides will overlap a bit, but I really want to give you an update about status quo. As you know, ocular melanoma is a rare subtype. Patients tend to have low response rates to any drugs we have developed over the last 20 plus years, whether it's chemotherapy, targeted drugs, or even the immune therapies. And unfortunately, what we have seen is that patients often have been excluded from many clinical trials, and particularly basket trials, because often these tumors are so rare, and other more common cancer populations were included into clinical trials. So really a lack of access to clinical trials. And what I am very strongly in favor, because that is really where patients get benefit, and I will show you some of the examples, is that patients with particularly metastatic disease have access to clinical trials, often through the phase 1 units around the country, and with that always access to molecular profiling, because that's really what I want to, as a take-home message, already tell you here. Lots of understanding comes from biology through genetic testing. This is kind of an update where and what clinical trials for uveal melanoma look like. Effectively, 190 studies are open on clinicaltrials.gov. That's the largest global database on clinical trials. This really incorporates all modalities, as opposed to nearly 3,000 trials open for cutaneous melanoma. Again, you can see very limited numbers of trials. That's why it's so important, like your charity as well, guide patients, families, the community to these clinical trials, because they often recruit very quickly and are often in kind of early drug development unit, tertiary centers, only they're available. I found this article quite interesting. This was a workshop of the AACR, the American Society of Cancer Research, effectively to build a framework for an orphan disease like uveal melanoma. Orphan disease means less than 200,000 cancer diagnoses a year, so less than 200,000, and uveal melanoma is falling into this. And effectively, this workshop looked into how can we improve clinical trial setting, how can we as well, it's not only clinical trials, but help the regulatory framework to accept the clinical trial designs and effectively moving forward with approvals. And if you can see here,
sorry, can I just jump in? We can't see your slides at the moment. Could you look and see about maybe sharing screen?
I have put them up. They should be. Can you see them?
Nope. I wonder, do you need to go out and come back in again?
Yeah, let me have a look.
Go out and share screen and back in again. If you reshare and put in full screen.
Yeah, I have go on share screen, share screen in the window.
Full screen, not just window.
Can you see?
Not at the minute.
Can you see this now? If you get,
you need to do is reshare. Yeah, now we've got it.
Okay, so in fact, I'm very sorry. I thought I had this yellow frame around. So effectively, I started with the status quo, and I'm happy to share these slides, of course. Again, the numbers of clinical trials available. And I started to talk about the recent workshop of the AACR, where effectively regulators, researchers, particularly with focus on uveal melanoma, were sitting and effectively, how can we improve clinical trial designs? How can we set benchmarks for success? And effectively, if you look at 29 trials, they analyzed in a meta-analysis for metastatic uveal melanoma, the PFS, progression-free survival, was around 3.3 months, 1 year overall survival about 43%, with the median overall survival of 10%. That's effectively the reality, a meta-analysis of 29 trials. And the regulators were pretty supportive of effectively endpoints like response rates in the range of 15% with meaningful, durable responses being recognized by the agencies, in this particular case, the FDA, towards further investigation. Again, as an orphan drug disease, they would consider the agency's non-randomized clinical trials, which then, if a therapeutic approval happens, would need confirmation in randomized clinical trials. And also for the effectively comparator arms, they would recognize, for example, treatments with MEK inhibitors or combinations of nivolumab or ipilimumab. So again, this is the US view. Again, why I'm highlighting this, not because it's a US view, but it's a very pragmatic approach of the researchers working with regulators on a effectively blueprint on how do we move often these clinical phase 2 studies, which and I will show you that there have been so many phase 2 studies, all with some endpoints, but effectively not really on the path for regulatory approval. That's really important. And again, as drug developers, working with biotechs, it is absolutely relevant to have this framework in mind to effectively make these drugs successful and benefit patients. I will again give a brief overview on the immunotherapies and what happened there. I'm also updating you on some of the recent ESMO data, ESMO, the European Society of Medical Oncology. There have been some updates on uveal melanoma. And Paul already showed the data of Ipi-Nivo. Again, these were data from the US, small patient numbers, 50 patients, with overall response rates of around 18%, survival around 19%. Again, these are the largest studies, 50 patients in this context. A Spanish study here as well, with median overall survival of 15 months and a response rate a bit lower. ESMO has updated, this was an ASCO presentation, updated us effectively the studies which were conducted. 8 studies were included where patients were treated with nivolumab and ipilimumab, and included nearly 380 patients. Again, confirmed that the overall response rates are in the range of 14%, with the median overall survival ranging between 12 and 19 months. So pretty much what the single studies have shown, these larger kind of pooled analysis has confirmed this. Of course, and as Paul already mentioned, there have been significant toxicities, particularly immunological toxicities like colitis, diarrhea, liver toxicities, and so on. So although in the US, and again, this meta-analysis confirms it's a reasonable option and it is widely used as opposed to single agent drugs, one has to bear in mind that toxicities are quite significant. And compared to cutaneous melanoma, the combination were actually not that exciting. And I think this slide may get a better understanding, and this is particularly focusing on biology, why checkpoint blockade doesn't work as well in uveal melanoma. On the left side, you see a slide in these red dots, uveal melanoma very much on the lower left side, and cutaneous melanoma very much on the right upper side. And what does it mean? So effectively, you're looking here at objective response rates. So the higher you go on the right side, the more response, up to 40% for melanoma, in uveal melanoma around 5 to 8% a single agent. And if you go onto the right side as well, looking at the numbers of somatic mutation, so effectively we see that uveal melanoma has a very low rate of mutations, which effectively would, the higher they are, cause immune response. That is one factor, and we see, for example, melanoma, lung cancer, some subtypes of colorectal cancer. They're sitting on the right side, up in the corner. They usually have very high numbers of somatic mutations, and therefore can result in immune response and get better response rates. On the right side is as well what we often use as biomarkers to select patients who are likely to respond. PD-L1 programmed as ligand, as a receptor. In the cutaneous melanoma, this is in a range 26-27%. In ocular melanoma, we have only 5% of patients expressing PD-L1. So this may be an explanation why checkpoint blockade, these surrogate markers of tumor mutational burden and PD-L1, very lowly expressed in uveal melanoma as opposed to cutaneous melanoma. Tebentafusp, Paul already mentioned, and again, he has been the lead author in of course, the landmark paper published last year in the New England paper, a bispecific fusion protein targeting CD3 and GP100, presented by the HLA. That's again treatment only for patients who have these HLA-2 presentation, 50% of the Caucasian population, as we already heard. Several trials were ongoing over many years, but again here, Paul's study presented last year, really the breakthrough with a meaningful overall survival. And meaningful, what does it mean? Effectively, 49% risk reduction in deaths, and 73% 1-year survival. It's really a breakthrough as opposed to the standard of, or compared to standard of care treatment. Unfortunately, you can't give Tebentafusp to all patients. So again, we have the other 50% who are not HLA-2 expressors. So we need to find treatments for those as well. I want to give, in the context of checkpoint inhibition and Tebentafusp, 3 abstracts which I found interesting, which were presented at ESMO just a few weeks ago. Here, inverse probability treatment on which of the treatments, although not head-to-head compared, has better outcome. And effectively, this included 2 studies, the 202 study and the GEM 1402 study, where patients were treated with ipilimumab and nivolumab against Tebentafusp. And you can see that in terms of overall survival, the hazard ratios are in favor of Tebentafusp over ipi and nivo. That brings me to another point. Again, this is thought-provoking. This is retrospective analysis, so you have to always take it with a bit of pinch of salt about the sequence of how would we give patients if we could give these drugs freely right now, and sequence them in a way. So think strategically, what do I do first? And this is a study where effectively retrospective analysis has been performed. Are you giving Tebentafusp first and then immune checkpoint inhibition, or the other way around? Do you give immune checkpoint inhibition followed by Tebentafusp? And here, in this very limited patient number, it looks like in terms of progression-free survival, there is a slight favor in terms of giving Tebentafusp first before immune checkpoint inhibitor compared to the other way around. At this point, the overall survival are not mature. There's no difference, but again, this is thought-provoking, limited numbers, but certainly something which will continue to be explored in research studies. Then another one on Tebentafusp, effectively retrospective analysis here presented at ESMO. The baseline predictors for long-term survival, who are the patients who do long-term very well, and they're classical markers like LDH, alkaline phosphatase, but also an interesting new potential biomarker, predictive biomarker, circulating tumor DNA. So patients who had an early reduction in circulating tumor DNA or clearance of that had better overall survival. So again, always with a bit of pinch of salt, but hypothesis generating. These were baseline characteristics. Are there predictors of the drug response, or were they just prognostic factors? So again, we need to look into this in more detail, but interesting, thought-provoking questions. And we've presented an interesting new immunotherapy drug, a new ImmTAC, similar to Tebentafusp. Again, instead of targeting the GP100, this particular compound as well through Immunocore targets PRAME. PRAME, and again, this was a phase 1 study for all comers. And PRAME plays a major role in a variety of tumors, including uveal melanoma, and works very similar to Tebentafusp by engaging with the CD3 receptor on T cells and targets PRAME, which is presented by the HLA-02. And don't want to go too much into detail here. Phase 1 dose escalation study. We recruited in the safety cohort 26 uveal melanoma patients and in the efficacy 11. So again, this is an ongoing phase 1 study, early data. Again, a bit different, but also very similar to Tebentafusp. And in line what these drugs would do, they're effectively engaging the immune system. And what we have seen and watched out in these particular early clinical studies is the cytokine release syndrome, where blood pressure can drop and patients can get fever and need to be monitored effectively. Treatments we just can't give in the outpatient, but patients have to stay in for a night and need to be monitored. But generally very well tolerated. What I wanted to show you here is that We have seen responses in the Tebentafusp naive patients uveal melanoma, so 50%, quite encouraging, more than 30% tumor reduction. But also, if you look into column 4, patients who have been treated with Tebentafusp, although they didn't have response, they had disease stabilization. And if you look into these, what we call spider plots, so everything turning to the right and moving on the right, it's effectively duration on response. And you see lots of dark blue and light blue. So patients dark blue are the patients who were treated with Tebentafusp. Although they didn't have any response, they did actually quite well. And even if they were kind of slightly progressing or in the stable disease range. So very interesting, and this needs to be further investigated. And then the Tebentafusp naive patients as well did quite well. And you can see this here in what we call in our clinical trial setting swimmer plots. The first box in red effectively the Tebentafusp naive patient did quite well with partial responses, but also I found that quite striking. Patients who had prior Tebentafusp did quite well for even if they had only disease stabilization. So interesting to watch. And again, I'm coming back to the circulating DNA. Again, what we have seen in the Tebentafusp retrospective analysis from ESMO seems to be here that patients who clear their circulating DNA do better and not do better, but effectively show that you can correlate this with response and possibly can use this long-term as a surrogate marker of response rather than using imaging. And these are the patients we have treated, for example, with very good partial response. Okay, I'm moving now. So you see, again, the flavor is effectively immunotherapies beyond checkpoint inhibitors are moving on. We're getting better. We're getting more targets. And I think that is very encouraging. Targeted therapies, I want to briefly comment on the molecular profile of the melanomas. We often know the tumor-initiating mutations, GNAQ, GNA11, and others. Again, signature genes, which are often activated in uveal melanoma. And then also we have identified prognostic mutations, like BAP1, for example, a more negative prognostic marker. So that's why I think it's very important to understand biology upfront, and in addition to this, often through next generation sequencing, more broader gene panel, we see prognosticators like BAP1 and so on as well. So if we think here at the signaling pathway activation in melanoma, and again, this is a rather complex slide, but effectively shows you the signaling cascades, the interaction between those. So these pathways with arrows shown here, and these red boxes, effectively how different drugs, different mechanism of action try to tackle these signaling cascades, which are so often activated in uveal melanoma. So the red boxes are effectively new drugs in development to stop these intracellular signaling. And I want to comment on this, and Paul already mentioned this. Darovasertib, again, for all of us, very difficult to spell, and because it's pretty much just off the market, got a new name. But again, here from a clinical trials point, I want to show you that this drug has not necessarily been developed purely for uveal melanoma, but also for other tumor types, because you can see this drug, a first-in-class protein kinase inhibitor, effectively stops signaling of the GNAQ mutation in GNA11. And this is on the right side activated in a variety of tumor at a lower range. In uveal melanoma, about 95%, but in cutaneous, colorectal, pancreatic, anything between 2 and 5%. So quite relevant in these more larger tumor types. So what this company IDEA has done, effectively developed a phase 1 study in terms of dose escalation, but then also very early on, because they found in preclinical evidence that by just singly only block the PKC, they went into combination with MEK inhibitors, binimetinib or crizotinib, the c-MET inhibitors, to effectively get a dual blockage. And as this happens, just 10 days ago, and Paul presented this, the company did a press release. They were very excited about their PKC inhibitor here in combination with crizotinib, a c-MET inhibitor, effectively they found 31% overall response rates in heavily pretreated patients, any line of treatment, but also, which is really encouraging, in the first line. So patients who have not received any treatments upfront, 50% of those patients had overall response rates. And that's really encouraging. Median overall progression-free survival hasn't been reached, or certainly more than 5 months. And effectively, this press release just was about to announce that they're starting a first-line uveal melanoma combination in Q1 next year. So watch out, and effectively, it's really important that all the centers, possibly treating uveal melanoma can participate in this clinical trial. I think a real great option for those patients. Then another, I think the interaction, you've seen the slide on the right side, the what we call intrinsic targets activation, but also often the interaction between intrinsic and extrinsic. What does it mean? Extrinsic effectively means microenvironment, T-cell engagement, and in particular, the involvement of T regulatory cells, which often make the microenvironment very immune hostile. So that's probably as well that immune therapies or checkpoint inhibitors don't work so well, but there is certainly an interaction between the intrinsic and extrinsic pathways. And we know, for example, here in patients with BAP1 mutations with very poor survival prognosis, that those patients also, those tumors activate genes which suppress the microenvironment and the immune response as well. So, and again, here, don't want to bother you too much. There is a correlation between specific gene, the PLK3CD gene, and an upregulation of Tregs. Effectively, a company, Altura, developing a drug, IOA-244, in this context, effectively to block this PI3 kinase delta as a delta inhibitor, and therefore reducing Tregs, which effectively causes hostile environment for immune cells, and therefore reprogram the immune response. Again, a selective PI3 kinase delta inhibitor as opposed to alpha or pan PI3 kinase inhibitor. Again, this study was presented at ASCO, dose escalated, and already expanded into uveal melanoma. And what you can see here is a response in Tregs in blood and tissue, a reduction. So Tregs, the T-cell regulatory cells, effectively, they're the ones you don't want around your tumor cells because they're effectively causing these bad microenvironment, and a reduction of those, and the reprogramming happens. Drug was so far very well tolerated. I think what was encouraging as a single agent, small molecule, you can see the orange swimmer lines with the arrows directing towards the right side, ongoing responses in these patients. If you compare the gray line above, the previous often single agent immune checkpoint inhibitor therapy, this drug certainly resulted in some longer outcome compared to the previous therapy. Again, this has always been seen in the context of as well combination EP-Nivo studies, but certainly encouraging. The other relevant targets, again, MEK inhibitors, a single agent, have been kind of borderline exciting, but again, combination studies going on. There will be more and more drugs developed in specific genetic alteration, like BAP1, for example, PARP inhibitors ongoing in this setting, and other, including epigenetic targets. So for me, I want to stop here. My advice, my summary here is really for patients, ask to participate in a clinical trial. It really doesn't matter whether it is an early clinical trial or late-stage clinical trials. Participate in a clinical trial and discuss it with your doctor, your team, in the context of the disease. Get ideally your tumor molecularly profiled, and as Paul already said, there is of course debate, there are guidelines, but again, the more you understand about biology, the higher the chances to participate in clinical trials. Engage with the charities. I think for us as research community, we really need to do better clinical trials, make use of the just generally more friendly regulatory framework, support of basket or umbrella studies, incorporate new biomarkers like circulating DNA in the right context and with the right hypothesis, and engage with regulators. I can only can't stress this enough. They really want to make sure that better trials are developed. And I want to thank you here. Thank you very much.
And thank you so much there, Toby. That was really impressive. Firstly, impressive that you understand the science. I think it's quite daunting for patients looking at some of these slides, but actually incredibly reassuring to know that we have people with the kind of phenomenal level of knowledge that you and Paul have, who are actually looking at things and really breaking it down into the most minuscule detail. And your final message there, take part in trials, I think is one I can only reiterate. It's just so important that if you're in a position at all where this is something that should be for you, then always ask about trials. And now, as we're getting established treatments that we're developing, you won't be in a trial where your standard arm is something that doesn't work at all. We know that in future trials, you're going to be comparing what is the standard of care now that actually has, admittedly, at the moment, still only small benefits, but with each decade, it's going to be bigger benefits. So it's really important to be in those trials. I think we've got some questions. Is Paul going to come back in and join us now?
Hello there.
Yeah, thank you very much. Let me see if my eyes are good enough. So the first one is for Paul. RP2 has been in the news this week. What are your thoughts to this treatment with herpes? And is that a supplementary question or?
Yeah.
I think the next, go for that.
Yeah, thanks. So thanks for the questions that are coming through. Neil, I might pick off a couple of others as well while I answer that one, just if that's all right. So and thanks for a super talk, Toby. That was excellent. So RP2 is a modified herpes virus. There were a cohort of uveal melanoma patients on the RP2 study. It's one of a number of approaches that are early in development, and certainly there's a modified herpes vaccine, a herpes virus that we use routinely for cutaneous melanoma called TVAC, and effectively this is a similar principle, but kind of taken one step on. So it's a principle where we know that you can get anti-cancer responses. I guess the challenge is with all of these things, they tend to require intratumoral injection of virus. And that's sometimes a challenge for patients with metastatic uveal melanoma. And these are early things in development. So it would be foolish of anybody to be able to speculate what the overall benefit is of a RP2, or in fact, there's another one coming, RP3, compared to other options. But I think the key message is when you're in a situation where you're looking at needing systemic treatment, that there's a conversation that covers the pros and cons of standard available treatments and clinical trial available treatments. And I think that's the key thing that we want to encourage, that discussion. You'll appreciate that with things early on in development, the reason they are early on in development is because we don't know very much about them, and therefore it's difficult to be very directive about them. Neil, there's a question on improving immune systems and things. Do you mind if I take that?
Yeah, just go for it.
So somebody's asked about what can you do to improve your own immune systems, and I'm really quite keen for all of our patients who I know are often in a difficult situation, and lots of well-meaning family and friends make all sorts of suggestions about complementary treatments, alternative treatments, dietary changes. some of which can have a major impact upon quality of life, and often without any significant data to justify those changes. What we are learning is that with immune checkpoint inhibitors in cutaneous melanoma, that there's an association, appears to be, between the quality of the bugs in your gut and the likelihood of benefit from immune checkpoint inhibitors if you've got skin melanoma or indeed renal cancer or some other cancers. And in fact, there's a national study that we're leading. We published recently in Nature Medicine, which is an important journal, comparing bugs in guts in UK patients with those in Spain and those in Holland. And the bottom line is that the diversity of bugs in the gut are important rather than which specific bug it is. So we're encouraging people to have Mediterranean-style diets, not to eat processed food. That's really important. If you eat processed food, it wipes out the diversity in your microbiome. And we don't like prebiotic drinks. So these things of soups with various bugs in there, they do repopulate the gut, but they're not with the right bugs that are associated with improving immune responses. And there's some data from Israel on that. So Mediterranean diet, some sauerkraut, some kimchi, other things, lots of exercise is good, but don't go on any fad diets and don't try and starve yourself. And that's important. Okay, Neil, thank you. I've got that off my chest.
Thank you so much. We do have a lot of questions here. So another one is, do you have any knowledge or thoughts on dendritic cell therapy and possibly the current German trial?
Toby, do you want to? Do you want to pick that up?
Yeah, I mean, I personally have done various different dendritic trials and various different other tumors, but not personally experienced with in uveal melanoma. I personally, in some studies, particularly in the GI cancer scenario, they have been rather disappointing, or GBMs, brain tumors. I assume that this is the case. Again, they're ongoing trials. That's why we need to, look obviously on what the outcome is of these trials. But personally, I've been rather disappointed. The concept is interesting. Effectively, what do dendritic cells? They present the antigen, and they present in a way that the immune system is getting activated. But so far, overall, I've been in experience from different tumor types rather disappointed. Paul, maybe your comment on this?
Yeah, no, we did a dendritic study a long time ago in cutaneous melanoma, and it was negative. I guess the other thing I'd say is that I think you have to be really careful about traveling abroad for a clinical trial, partly because you end up going there without all of your support network, and that's an important thing. And becomes really difficult. I won't take anybody on a clinical trial who doesn't live in a safe distance from me, so that if there's a problem, I can pick it up and we can manage patients appropriately. And I think if you're relocating for in the hope of something that is going to be markedly beneficial, when in fact there's there might be little data to justify that huge change in quality of life and support networks, I think you have to be really quite careful about that.
Yeah, I would agree. I would agree, and it should be principle of any clinical trials unit to ensure. You have seen some of the data with whether it's Tebentafusp or the PRAME drug. Patients can get very sick, and these are very early clinical trials, and we need to be sometimes realistic and again experience these drug side effects before we let patients go. And comment on Germany, unfortunately there is a culture out there to do lots of things which we would never do. So you get dendritics all over, you get vaccines in Germany pretty much not at any corner, but in reputable centers as well, not as part of clinical trials, but you have to pay for this. And I find that not the right approach. So there's so many interesting trials coming in. Germany is the last resort. I'm always joking. You rather eat sauerkraut. It's much more keeps your gut microbiome intact. Have a bit of kefir. and that may help much more than some of the dubious things. Sorry to say this so clearly, but we need to be realistic, and I think these any immune treatment or vaccine treatment outside a clinical trial, I can't support.
Thank you both for that. The next question relates to immunotherapy. So perhaps there's one for Paul, and it's for somebody who's on immunotherapy. At what level of ALT and possibly other markers would steroids be introduced? And what would make you stop or suspend the treatment?
Yeah, there's not an absolute number there. So it's I understand where the question is coming from, but it's an impossible question for me to answer. I think the key thing about these things is to make sure that the reality is that you want your immunotherapy to be managed by people who are experienced in managing these toxicities, and there is not an absolute number. It depends a lot on patient fitness, what's the cause, whether the disease is responding. I would be wary about an absolute number. So it's, as you would hope, it would be an individualized thing, because all cancer care should be individualized according to the biology of the patient. So I'm sorry I can't be more specific, but I think it would be I'd be giving misinformation if I was being more specific.
Yeah, no, I think you're right. Speaking as a one-time liver surgeon, when you're looking at liver function, there's many different ways of looking at it, and this is definitely a bit where you've got to practice the art of medicine as well as the science.
Shall I pick up? There are two questions on HLA testing, and then
yes, please.
And then there's some questions about relatlimab, and I'm sure Toby will have a view on that. I might have a view. So two questions on HLA testing. It's a very simple test, and you can be tested in a number of different ways, and it's the sort of test that most blood transfusion services will run, because they need to do HLA testing for a variety of things. The key question, though, for any test is whether it's a helpful result. So there's a question is, well, should you be tested for HLA if you haven't got metastatic disease? And I'd say, well, I'm not sure. I don't understand why that would be a helpful result, because number one, of course, everybody would hope that there would never be a future relapse. But even if there is a future relapse, you don't know what the standard of care will be when you have that future relapse, and you don't know what would be a relevant test. You can already see how things have changed so significantly in the last 2 or 3 years. For people who have got metastatic disease and for whom Tebentafusp is a potential option, then absolutely they would be tested, and it's straightforward within the remit of any local cancer service to be able to HLA test.
Yeah. So as patients, if you've got metastatic disease, newly diagnosed, it is something you could ask for.
Yeah, I guess the one proviso I'd say is that for those of you who are aware, so Tebentafusp is licensed, but it's not yet reimbursed by the NHS. There's an expanded access program, or a named patient program, run by the company, but only a handful of hospitals are able to run that program because NICE hasn't yet approved it. There are quite a lot of costs associated with delivering it, because patients need overnight stays. The pharmacy costs are significant as well. It's not the most straightforward drug for pharmacies to make up and reconstitute. So access to Tebentafusp is difficult at the moment. It will become easier if NICE approve it, but I don't know when that final decision is going to be made. And so again, I'm a little bit wary about encouraging people to be tested for something that's not yet available, because it's not helpful.
Yeah, no, it's a difficult situation. What's your gut feeling? Do you think NICE will support this with funding? Or
well, look, so I was the external expert at the NICE committee meeting.
Yeah,
and I've been in that position a number of times with NICE, and the one thing I've learned is that I can't in any way predict what they're going to come out with, because it's a behind closed door thing. Of course, the external experts are not party to.
Yeah.
But it's that balance of a negotiated price deal with a company that is suitable, together with a belief that the benefit is great enough. And that's always a challenge when you've got a new drug that's expensive, and when you've got a drug that's not been around for very long. So it's difficult to know what the long-term benefits of treatment are, because the drug's not been around for long enough to be certain about the long-term benefits of treatment.
Okay, thank you. Another question. You both mentioned cytokine responses. And who are you able to predict and understand why some people get that cytokine response and others don't?
Shall I take that, Toby? Just
Yeah, sure.
A bit in the, so with you'll be glad to hear that we call Tebentafusp Tebi. It's a bit easier to roll off the tongue. So with Tebi, initially we thought that there was an association between the rash, which is a part of a cytokine release syndrome that the drug causes, and outcome. Although in the larger study that didn't hold forth. We know that a lot of the cytokine, because this target, this peptide that the drug targets, is expressed on melanocytes, so skin pigment cells. And there's a lot of melanocytes in the skin. We do see a lot of rash with the drug, and that so the drug induces a lot of T cell activation, and the T cells release a lot of active chemicals into the bloodstream that result in this change, resulting in a lower this cytokine release, which results in low blood pressure and other problems. Most people get some cytokine release syndrome. It's much milder than other cellular therapies that Toby is more familiar with than I am, but it's nothing like the cytokine release syndrome that you see with cellular therapies like CAR T cells. It's a sort of syndrome where you just need to actively manage patients overnight, and you can do that on a straightforward oncology unit rather than a cell therapy specialist unit. But most people, for their first 2 or 3 injections, will have some side effects from it. The interesting thing about the drug is after the first month of treatment, those side effects wane, and then they can be treated as an outpatient and not require overnight stays. So it becomes much easier once you get through the first month of treatment.
I just wanted to say to add, effectively, the cytokine release syndrome gets better usually once you give the drug, and but in my clinic, you can't predict. We have seen it all, unpredictable cytokine release at various different times. Usually, it's during the day when patients have the administration. It's effectively why we, particularly with these cellular therapies, need to have patients 1, sometimes 2 days in clinic or overnight.
Okay, thank you for that. Another question. So this is a combination drug question. Do you think the combination of relatlimab and nivolumab is potentially more effective than ipi/nivo? I'm going to go for, I can see Paul nodding, so I'll go to Toby. How about that?
So, I mean, LAG3 is another checkpoint inhibitors, and obviously in cutaneous melanoma, this drug has been approved, it's been there. In uveal melanoma, there is an interesting story that actually LAG3 is highly overexpressed, and particularly in high-risk tumors. And so there is a role, there's some studies ongoing. Again, with, it's probably my cynical drug development head on that. We have done so many combinations of checkpoint inhibitors, and unless you really have a good, highly selected patient population group, I would be cautious. Of course, the trials are ongoing. We need to wait for the results. But in a selected group of patients with high LAG expression and a good, again, I've shown you PD-1 or PDA1 in uveal melanoma is not very highly expressed generally. This may be a biomarker and worthwhile to consider, but I haven't seen the results yet, so I'm a bit cautious.
Anything to add, Paul?
No, yeah, I kind of agree with that. So relatlimab is a drug that's paired up with nivo, and that combination looks less toxic than ipi/nivo. but the question is whether it's any better. And my prejudice is in skin melanoma, it's probably the same group of patients who benefit from these from a nivo-relatlimab combination as would benefit from an ipi-nivo combination. Now, if ipi-nivo is not very active in uveal melanoma, it may be that relatlimab nivo is not very active in uveal melanoma only. The one proviso is the study that Toby mentioned coming from Bill Harbour's laboratory, which showed that there is expression of LAG3 in and around uveal melanoma cells. So that's why we're doing a clinical trial. But certainly, I don't think any of us would recommend the relatlimab nivo combination as the way forward in uveal melanoma as a preferable way forward, because we don't have any data that's adequate yet.
Yeah. Okay. So the jury's out. Possible subtle benefits, but at the moment, not one to push. Another question about precision medicine and personalized medicine. Where are we now with that in uveal melanoma?
Well, it's, good question. Obviously, it is not generally, but if you talk about precision medicine, it's about finding the molecular driver, understanding biology. And unfortunately, what I see often in the clinical trial setting, that patients don't have genetic profiles, don't have supportive information to really get an understanding. Is this tumor driven by BAP1, or what's the role of BAP1 in these patients? So I cautiously encourage, although unfortunately widely genetic profiling is not done. So if I would, as a charity, probably you can help us, support us, that this is widely used in the centers where clinical trials are done, in uveal melanoma centers where profiling should be offered. I mean, there's certain standards you need to have, but there's more than this broader NGS, next generation sequencing panel. I would very much in favor. And particularly as well, you've seen in some of these early retrospective analysis from circulating DNA. Again, you're on treatment, you may see very early signs of DNA reduction in the bloodstream. Again, these are early studies. As part of studies, I would fully encourage this to further investigate. And particularly if you've seen with Tebentafusp, with the MAGE drug as well, that patients who even don't have a response and even slightly progress, they see DNA is clearing, and this might be a predictive marker of response or long-term outcome. So, encouraging as part of clinical trials, not Wild West, don't go to 10 different doctors and they do genetic sequencing and NGS or molecular profiling. Don't do this. I mean next generation sequence in the framework of clinical trials and as a good baseline understanding of biology.
Okay,
yeah, it's interesting. Can I just add very briefly to that, Neil? So I agree with nearly everything that Toby said, but I think there's an important message, which is that is about managing expectations, because what you get is a printout of a load of genetic changes in a cancer, and then there are two questions. One is, which changes are actually important in driving that cancer? We've got this issue where we know that some things are driver mutations, are really important to make it grow, and other things are called carrier mutations. So they're genetically damaged, but they're not important in that cancer growing. And the printout doesn't tell you which is a driver mutation and which is a carrier mutation. Mm-hmm. And then the second challenge is access to agents which block a particular target. And there is often not access to agents that would block a target suggested by sequencing. And therefore, that's actually quite a stressful situation for a patient to be in if they've got a piece of paper saying, oh, well, this looks like there might be benefit if you block this drug, but nobody can access it. And it creates all sorts of challenges. And then finally, the other health warning on these things is what you get is a readout of the wiring of the tumor, but it doesn't reflect often clinical experiments to know whether or not targeting that target really makes a difference. So BRAF is a target that we use really importantly in cutaneous melanoma, and we know that it's associated, if you target it, with lots and lots of potential outcome, improved outcomes. This exactly the same damaged gene is present in a small subset of colon cancers. But if you target that gene with the same drugs, you don't get anywhere near like the same benefit. And that's because it's not just the target that has to be there, it's the environment that the target is in. But the printout doesn't tell you about the environment that the target's in. So you've really got to manage expectations and look at these things in a considered way, and don't think that, well, because I haven't had an NGS or whole genome sequencing or whatever of my tumor, that I'm missing out on something that could have made a big difference.
I agree. And one final comment, the interpretation of these data is so important. So we have established now for the last 7 years a molecular tumor board, which doctors from UCLH and pretty much across London can submit their genomics profiles to make sense. And it's like an MBT. So a genetic report never give to patient without someone who's really an understanding of this. And I think that's just an add-on to effectively close the loop and make sure data are interpreted like a CT scan is. Agree.
Thank you both. I mean, yes, it's like a CT scan. Lots of it's in black and white, as well as some shades of grey, but it needs a lot of interpretation, and it's not always what it looks like. So one final question, which is thoughts on trials involving arginine deprivation. Do you think there's any role for that? Any potential benefit to restricting arginine in the diet? You keep nodding.
So I mean, so there is a bit of data. There's also some data in mesothelioma and some other cancers with arginine deprivation. It's an amino acid basically, and the idea is that cancer cells can't make their own arginine and suffer if they're deprived from it. But there are lots of good ideas that have not yet been tested in the clinic. So, and just because something is a good idea, it doesn't mean that it works in real people. So I would not recommend anybody changing diet in the absence of a prospective study that examines whether or not that diet change is beneficial. Just as I wouldn't recommend anybody taking any drug for the same reasons. Toby,
I totally agree.
Okay, well, that's pretty clear. Thank you for that. And can I thank you for your contribution? I mean, this has been, I think, a really phenomenally helpful session. Some great Q&A there. So I really appreciate that. And thank you to everyone in the audience who submitted a question. It shows that some of you know a lot more than me, which perhaps isn't difficult. I was only ever a surgeon. So having had 2 world leaders here during this session, we're going to move directly through into our next session.